Otosclerosis is a condition in which the middle ear undergoes abnormal bone remodeling. Bone deposits surround and adhere to the ossicles, impeding the mechanical transmission of sound from the middle to the inner ear. This process of abnormal bone remodeling is said to occur in three phases. The first phase, otospongiosis, is characterized by an increase in osteoclast activity and microvascularity. The second phase, the transitional phase, is characterized by spongy bone deposits. In the final phase, the otosclerotic phase, the spongy bone deposits harden. The location of the abnormal bone growth varies, although the primary site is anterior to the oval window and around the stapes footplate, which comprises approximately 80% of cases. Roughly 30% of cases experience bone growth near the round window, 21% of cases note growth in the periocochlear region, and 19% of patients experience bone growth in the anterior region of the internal auditory canal. Hearing loss is the most common complaint in patients with otosclerosis. Hearing loss due to otosclerosis is primarily unilateral at the beginning, but often becomes bilateral over time. Hearing loss may be gradual, and low pitches are often the first to be impacted. Patients suffering from otosclerosis may also experience tinnitus, or ringing in the ear, and dizziness or vertigo. The exact causes of otosclerosis are unclear. However, some risk factors have been identified. There seem to be strong genetic factors behind otosclerosis, with 60% of patients reporting a family history of the disease. Hormonal factors have also been tied to otosclerosis. In particular, pregnancy, puberty, and menopause have been observed to make hearing loss worse in patients who already have otosclerosis. Previous exposure to measles has been cited as a risk factor for otosclerosis, though the exact role of the virus in the development of this disorder is still unknown. Chronic inflammation due to immunological disorders has also been indicated as a potential risk factor for otosclerosis, although no specific autoimmune disorder has been pinpointed as a direct cause.
When patients first come in with a potential otosclerosis diagnosis, they typically state they're experiencing tinnitus, which is a perception of noise or ringing in the ears, and hearing loss. After initial testing, they typically have similar audiological features of other middle or inner ear dysfunctions. Those include air bone gaps, Carhart notch, normal or reduced tympanometric mobility, and absent acoustic reflexes. Therefore, patients require additional assessments to determine if they have otosclerosis or another middle or inner ear dysfunction. For example, when a patient experiences conductive hearing loss, meaning their air bone gap is greater than 10 dB and their bone conduction is less than or equal to 25 dB HL, it can be caused not only by otosclerosis, but also a variety of other dysfunctions, including tympanosclerosis, which is the calcification of tissue in the middle ear and ear canal, including the tympanic membrane, semicircular canal dehiscence, which is a lack of bone covering on the superior canal, congenital ossicular fusion, or when the ossicles fuse together, and even ossicular discontinuity, which is when the ossicles are misaligned. Some patients who have Meniere's disease can be misdiagnosed with otosclerosis, especially if the endolymph from Meniere's disease puts the saccular membrane in contact with the underside of the stapes footplate. Lastly, when a patient has intact acoustic reflexes with conductive hearing loss, additional testing is necessary to differentiate between early otosclerosis versus semicircular canal dehiscence or an enlarged vestibular aqueduct. Some patients may have sensorineural hearing loss, which presents with an air bone gap of less than or equal to 10 dB. Before diagnosing a patient with otosclerosis, examiners must rule out the possibility of an acoustic neuroma, which is a tumor growing on the vestibular nerves, or labyrinthitis ossificans, which is new bone formation on the membranous labyrinth.
There are a variety of ways that a clinician could assess a patient for signs of otosclerosis. Some of these methods include high-resolution computed tomography, magnetic resonance imaging, and vestibular evoked myogenic potential. During the process of high-resolution computed tomography, as explained by Bella Perowit, Robert Hermans, and Katja Optevik in their article Imaging in Otosclerosis, a Pictorial Review, a radiologist will take images of both the axial and coronal sections of the lateral semicircular canal, as well as some additional images if requested by a clinician, such as that of the stapedial superstructure, using a multi-detector CT scanner. The entire petrous temporal bone should be included amongst these images once they've been all collected. Overall, the main function of this audiologic assessment is to examine the size and location of plaques and the narrowing of the oval window. This method of assessment is most preferred by radiologists when examining a patient for signs of otosclerosis because it gives clinicians a clear anterior-posterior view of the stapes footplate and its crura. The images produced by high-resolution computed tomography are so clear and detailed that they are able to detect plaques as small as 1 millimeter in size. In the process of gathering data and research needed for their study, Perowit et al. Is able to obtain images that show the axial sections of the right and left temporal bones of a patient with bilateral otosclerosis. They are also able to obtain images of the axial and coronal sections of the left temporal bone of another patient with otosclerosis around their oval window, as indicated by the arrowheads in the picture above, as well as a conductive hearing loss and a history of otitis media. As previously mentioned, some of the benefits of this method of audiologic assessment include that it provides clinicians with clear, detailed images of the middle ear and gives them the ability to look at these structures from different angles and sections. It should also be noted that this technology can be used to analyze structures of the inner ear as well, which means it can be used to detect a particular type of otosclerosis, known as cochlear otosclerosis, which will be discussed in the following slides. However, there is one disadvantage to high-resolution computed tomography. Sometimes false negative CT findings will occur, especially if there are no irregularities of the bone contour, or a clinician is inexperienced in reading these types of images. With magnetic resonance imaging, it is usually used prior to high-resolution computed tomography scanning and is mainly used to look for signs of cochlear otosclerosis. The images produced by this type of audiologic assessment can detect new bone formations of the temporal bones surrounding the cochlea and may also pick up on other unassociated inner ear pathologies. This magnetic resonance image, also collected by Perowit et al. During the course of their study, shows the left inner ear of a patient with a sensory neural hearing loss. In this image, the patient's left cochlea is covered by a ring of bone as shown by the arrows above, which is indicative of cochlear otosclerosis. These images above show another patient with left-sided sensory neural hearing loss that also has this bony labyrinth surrounding the perimeter of the cochlea, a sign of cochlear otosclerosis. As stated earlier, some of the benefits of magnetic resonance imaging are that it allows clinicians to detect for signs of cochlear otosclerosis, and it may help to detect other inner ear abnormalities. One disadvantage to this form of audiologic assessment, though, is that according to Perowit et al., MRI has limited application in the evaluation of the bony growths associated with cochlear otosclerosis when compared to high-resolution computed tomography. Vestibular evoked myogenic potential is yet another audiologic assessment that has gained some recognition within the speech, language, and hearing sciences community over the past few years. According to the authors of the article Contribution of Vestibular Evoked Myogenic Potential, Testing in the Assessment and the Differential Diagnosis of Otosclerosis, this hearing assessment is mainly used to measure utricle and saccule functions and then interprets this data into waveforms on a computer screen for each ear, each type of stimulus used, and each intensity level. The reason why vestibular evoked myogenic potential measures the functions of the structures of the utricle and saccule is because the acoustic sensitivity of the saccule has been attributed to its proximity to the footplate of the stapes, which leads to its mechanical stimulation during stapedial motion in response to sound and can be measured. During this study, the authors measured the air-conducted and bone-conducted VEMP of patients diagnosed with otosclerosis to see how well this technology can detect a conductive hearing loss and a sensorineural hearing loss within individuals with this hearing disorder. The air-conducted VEMP was able to successfully detect conductive hearing losses within these patients as it managed to find a significant air-bone gap. However, the bone-conducted VEMP was not able to detect any significant indicators of a sensorineural hearing loss within the patients. In all, not only is this form of assessment objective, quick, and non-invasive, but it is a great way to be able to detect a conductive hearing loss in a patient who may have otosclerosis. On the other hand, this tool will not be very useful in detecting a sensorineural hearing loss in a patient with cochlear otosclerosis, as the results of this study showed that there were no indicators of a sensorineural hearing loss found in the patients. The above image shows the average preoperative and postoperative audiograms of patients diagnosed with otosclerosis. As you can see, after the patients had a procedure performed on them to lessen their conductive hearing loss, the airbone gap that was found in the preoperative audiogram is no longer present. The procedure performed on these patients was a stepidotomy followed by the insertion of a nickel titanium prosthesis. In these images shown above, the left image shows a sample audiogram of a patient with bilateral cochlear otosclerosis that was presented by Dr. DeFino during her lecture on selected disorders middle ear. The portion of the audiogram that describes the bone conduction hearing thresholds for the right ear shows a little dip or notch around 1000 Hz known as the Carhart's notch. This is a sign that is indicative that the patient has cochlear otosclerosis. The image on the right shows a graph of the average bone conduction hearing thresholds of a group of patients before and after they had a stepidotomy performed on them. After these patients underwent this procedure, the Carhart's notch, located around 2000 Hz, was not as severe as it was before the surgery.
When we begin to talk about the treatment plans for otosclerosis, there are two possible treatment plans for it. One being a hearing aid. For someone with a mild case of otosclerosis, a hearing aid can be given to amplify sound. The second treatment would be to get a surgical procedure done called a stapedectomy, which is usually recommended. The surgical procedure done for someone with otosclerosis is called a stapedectomy. It is a procedure where the surgeon inserts a prosthetic device into the middle ear to bypass the abnormal bone and permit sound waves to travel to the inner ear, to then help restore hearing in the ear. The surgical procedure can take about an hour to perform and generally takes 2 to 4 weeks for the ear to heal. With getting a procedure like a stapedectomy, there are some risks and complications that may come with it. Complications like hearing loss can occur due to infection, scar tissue, inflammatory reaction, or improperly sized prosthesis. Post-stapedectomy vertigo is also a complication that can occur that many people have after surgery. It is a sudden internal and external spinning sensation. Dizziness is also something patients experience due to things like quick head turns or getting up quickly. However, this usually only lasts for a day after surgery. Taste disturbance can also occur, which is caused by a nerve that runs under your eardrum that has to be moved to perform the surgery. Lastly, tinnitus can occur, which is a ringing noise in the ear. It is uncommon post-surgery, but most people still experience it. After getting a stapedectomy, the recovery period can take up to 2 to 4 weeks for your ear to heal, and the recovery period can be done at home. Some tips that are given to patients while recovering at home is to keep water away from your ear. Patients can plug their ears with a petroleum-coated cotton ball while taking a shower or bath. Avoid any strenuous activities for 3 weeks or until your doctor tells you to. That includes picking up heavy objects, jogging, aerobic exercises, etc. Avoid any air travel as this can prevent your ear from healing properly. Do not blow your nose for up to 4 weeks, and if you have to cough or sneeze, do not try and hold it in. As usual, drink a lot of fluids and get a lot of rest, which can help with your healing process. If there are any signs or problems like excessive bleeding, catching a fever, dizziness for a long time, swelling, or hearing loss, it is recommended that you contact your doctor.